Well, hello and good evening, everybody. It is wonderful to be joining with you this evening. Welcome to July's Thoughtful Childbirth webinar. And tonight we're going to be looking at Cascade of Cascade of interventions and the ins and outs of Caesars. For those of you who may not know me, I am Lynn Bluff. My background is a nursing sister and a midwife and internationally certified childbirth educator. And really, I am about having passion about informed choices, evidence-based birth, letting people know their options so that you can come out and say, man, that was the greatest birthing experience. How it actually unfolds is not what is so critical, but that you can say it was a good birthing experience. Thanks to Jason, Tammy, and Seth behind the scenes, helping us run this evening smoothly. In case you don't know us at Baby Talk, we have a wide range of information to offer you. So please do go and check it out if there's anything that you don't know about. We do the Expectant Mother's Guide and Expectant Father's Guide publication. They join together, so you only have to have one of them. The mom's guide is one side and the dad's guide is the other side. And really, it's a factual educational publication, again, helping you make informed decisions about your pregnancy, your birth, and your parenting journey. It is available as a print edition as well as a online edition at expectantmothersguide.coza, as well as downloadable as an app, both from Google Play and the App Store. As well as we've got the Expectant Mother's Guide Journey app, so you can read both the magazines as well as have extra information and all sorts of exciting things to be linked to. They're all free to download, so please do go and check them out and enjoy the great information that is available to you. We have a digital collated monthly newsletter called tomom.me or to mommy. And really, we know you want to read off the internet, but if it's not your field of expertise, are you reading good stuff? And it's hard to know that when you don't know what is good. And so we direct you to really good evidence-based websites so that you can go and read interesting articles and you know that the information that you find on that website is really good, up-to-date, evidence-based and reputable. And so then you've got some really great resources to read from as well. We offer consults on birthing options and informed choices. We run these free monthly webinars for pregnant moms and dads called Thoughtful Childbirth. Our program for this evening, it's really a loose program. We're running through till roughly about 9 o'clock tonight. We will stop for refreshment break around 8ish. So there will be a time for you to, go and grab something and be refreshed. We'll be looking at cascades of interventions, ins and outs of Caesars, gentle Caesars, and if there's time after that, we'll be looking at water births too, because we haven't covered that as yet either. So tonight is all about choices. Some easy, some hard, some fun, some difficult, some scary, some painful to make, but hopefully we will help you on your way to making really good choices. Now, there is a time and a place for all interventions. Okay, we cannot deny that the best for the average normal mom and normal baby, a normal birth far outweighs with the most fantastic benefits for both mom and baby. That is what one should be striving for if you haven't got any complications, because it is, women are made to birth. Babies are meant to be born vaginally, and we can't mince our words and say, oh, it doesn't matter which type of birth you choose. Okay, so we want to strive for a normal birth, but there's time and place for every intervention. But it's got to be the right time and the right place and the right intervention. But you should know what the benefits and the risks are that go along with that particular intervention, so that you are able to make informed decisions. It's so easy to say, yes, I'll have an induction, I'll have a Caesar, I'll have an epidural, okay? But what we say yes to when we agree to one of those things is that we actually say yes to a whole lot more interventions happening. It has a waterfall cascade effect of interventions and complications. And we're going to have an in-depth look at how they're all interrelated. Now, it's just important to actually understand the bigger picture, so that when you are offered an intervention or need an intervention, you actually understand the benefits and the risks and what could potentially be some of the complications. Obviously, not all of them will occur with every single person, but the potential is there. So we want to have a look at it in a very concrete way. So that's the big overview. Okay, in the green writing is the intervention, and in the orange writing is the complication that goes along with it. So I'm going to, hopefully you are able to see that in a way that it can actually be read. So let's start off with an induction, okay? And we'll go into a whole lot more about what an induction is and how to induce it, and how one can actually be induced. But if you take on or are offered an induction, okay, an artificial way of starting labor, you will probably have a drip up, an IV line. In that drip, you will have syntocinon, a drug that is there that artificially causes your uterus to contract. Okay, that sounds good and well. That's actually what we want to achieve. When you start somebody artificially in labor, you want to actually achieve contractions. But syntocinon will often give you strong contractions, okay, and they are stronger than, and the strongness and the intensity of the contractions comes along quicker than generally a slow incline that happens when you are in normal natural labor. So because the contractions are really strong, we are more likely to need some form of medical pain relief. That could be something like an injection of pethidine. And what pethidine actually does is that it will obviously go through the placental barrier and it will go to your baby. And so your baby will be put on a high of pethidine. And so your baby can come out a bit high, a bit woozy, a bit sleepy. And that can interfere with skin to skin. Okay, that as a baby is born, really they should undergo the non-instinctive stages resulting in latching, breastfeeding, okay, and this pethidine can interfere with this process of skin to skin. This can leave the mom with an increased risk of depression. For the baby, interfering with skin to skin is going to cause their baby to have increased crying, decreased temperature regulation, decreased heart rate and breathing stabilization, and increased sleeping problems, because those are all the things that skin to skin actually are counter effective with. Okay, also, with this interfering to skin, there could be bonding problems with mom and baby. The skin to skin and not letting their baby undergo those non-instinctive stages where they instinctively actually latch on the breast, that can lead to breastfeeding problems. Okay, perhaps a poor suck, a poor latch. When a baby's got a poor suck and a poor latch, they're more likely, the mom's more likely to become engorged with her breasts. Okay, it can cause stasis, just this milk lying in the breast, not being effectively taken off, can lead to blocked ducts in the breast. And that can actually, for a lot of people, just be the beginning of the end with breastfeeding, and say, actually, this is just too much to deal with all these problems. Because this baby isn't feeding really nicely, that baby becomes more likely to become jaundiced and need phototherapy. And that actually causes a baby to be separated from mom, because this baby needs to go under phototherapy. Okay, with the cessation of breastfeeding, obviously we're more likely to have a despondent mom, okay, because she ideally wanted to breastfeed and there's just been too much to actually deal with. And so now these feelings of inadequacy, of depression, of I just can't achieve what I really want. Okay, looking at these breastfeeding problems, because that baby isn't sucking nicely, because there's a poor latch, that baby is more likely to damage the nipples because they're not getting a good, effective suck and latch. They are not alert. They are not able to respond naturally to the way that they should to actually latch on the breast. And once we've got damaged nipples, it's very easy for the nipples to become infected, and we're going to need more medication and more intervention all the time. Okay, so that was just one line that we have jumped through in this entanglement of this cascade. So let's go back again to the top, where we're looking at an induction. You've got your drip up, you've got your IV line. And one of the problems that we'll discuss more later is that because you're not waiting for your body to go into labor, you might actually, it's more likely that your baby could be born prematurely. Might have got the dates mixed up, the scans, say, oh, this baby's a good size, but actually this baby can still come out prematurely with an induction. And if we have a look where this goes, a prem baby might need to have some intervention. It might need oxygen, it might need an incubator, might need to go to the neonatal intensive care. And again, we are going to have this interference with skin to skin, bonding problems, separation, okay? a premature baby has feeding problems. The sucking reflex might not actually be strong enough to suckle from the breast. And so there is going to be all those same problems occurring: poor suck, poor latch engorgement, blocked ducts, stopping breastfeeding, damaged nipples, infections. Okay. Another problem, okay, that is potential when you have an induction. You have the syntocinon put it up. You have this syntocinon causing your uterus to contract, but actually these contractions don't always actually kick into proper contractions for labor. And so you can actually experience what is called failure to progress. Okay, that you've got these contractions, but nothing is happening at the cervix. Now, it's the cervix that needs to open, it needs to dilate, it needs to thin out, it needs to efface. It needs to move out of the way so this baby can actually move through to be born. And so if there's failure to progress and that cervix stays tightly closed, okay, again, we are then going to go onto this complication, okay, that you are much more likely to need a Caesar, because we've got so far, okay, and we can't turn the clock back, and now we need this baby out. The cervix isn't dilating. Baby can become distressed because of all of these very strong contractions. And so we have a Caesar. Now, as far as babies go, when they are born by cesarean, they have a 20% higher risk of developing asthma, a 20% higher risk of developing type 1 diabetes, potential 20% increased risk of becoming obese, and a 15% increased risk of celiac disease. So one's got to understand that a Caesar definitely comes with risks, long-term risks to your baby. Talking about that though, okay, if you can successfully breastfeed, okay, it will take a little bit more patience, endurance, okay. Breastfeeding will help counteract some of those risks that are attached to that baby being born by cesarean. It won't counteract all of them, but it will certainly have a tremendous effect. As well as the fact that when a baby is born by cesarean, the mom is generally, before the Caesar, given antibiotics, and the antibiotics will cross over to the baby. So the antibiotics actually are going to interfere with that microbiome, those microorganisms that are so vital to giving you and your baby and everyone a good immune system, a good healthy gut, okay, and a good healthy road to a healthy pathway for life, okay, where it interferes with the microbiome and one can be negatively affected. Again, breastfeeding helps counteract some of that effect, but obviously it's not as good as the original, which is your vaginal birth. Okay, even for the mom, okay, antibiotics are going to interfere with her microbiome, her microorganisms, and that can cause a secondary infection, okay, that I'm sure you know somebody or in yourselves, okay, you take antibiotics because you've got some form of infection in your body, and before the course of antibiotics is complete, you actually have thrush, vaginal thrush, oral thrush. Thrush can absolutely occur everywhere because of this lopsided effect now that the antibiotics have knocked out the good microorganisms and give rise to secondary bad ones. And so then you are going to need to go on to antifungals to actually counteract the thrush that has been caused by the antibiotics. Okay, I'm sure you're starting to see the picture, how one thing leads to the next and leads to the next. So let's see where else we go with the syntocinon. Okay, I think, okay, all right. So with the syntocinon, we actually said that you can have very strong contractions. The contractions that are artificially produced, okay, are very much more intense and probably will lead to needing some pain relief measures that we said, but this intense pain can lead to a difficult birth and can lead to post-traumatic stress disorder because you are now not getting the birth that you really wanted, hoped for, and instead of it being a wow, good experience, it actually becomes a negative experience because of this cascade effect. These strong contractions, okay, with the birth, you are at a higher risk of bleeding post-delivery. Okay. And I think that basically is going on here for your interventions, for your inductions. I think that's about it. Okay, so let's move across to the other side that one says, okay, I want an epidural. Okay, yes, I'm experiencing contractions. Yes, I want some pain relief. And yes, actually, there is a problem. So we decide we go to have an epidural. With an epidural, okay, you are going to have a urinary catheter, okay, put into your bladder because you will no longer have control over your bladder, enabling you to wee, okay? Some people are very, very prone to bladder infections, and so this catheter can lead to a bladder infection or a urinary tract infection. With that type of infection, you have a fever, you need antibiotics. Again, we get that change in the mom's microbiome, causes a change in the baby's microbiome, and that causes an increased risk of childhood asthma. Okay, the other thing with an epidural is that we have a drip up, we have an IV line, okay? And we need that to counteract. When you have an epidural, it drops your blood pressure, so you put in extra fluids so that your blood pressure doesn't drop and you don't have that side effect. But actually these increased fluids that you get intravenously can cause other issues. And that being one, that your nipples may become swollen with this excess fluid. If your nipples become swollen, okay, again, your baby's going to find it very, very difficult to latch and hence suck on this breast. It's just going to hinder that whole setup, okay, that is there, okay, which we don't want. Breastfeeding, having a baby is challenging enough if everything just goes smoothly. if we have all these extra problems, it is just like this huge mountain that we got to climb with everything, and particularly with breastfeeding. Okay, also having a urinary catheter and having IV fluids up, okay, and the fact that when you have an epidural, for the majority of people, they're not going to actually be walking around to the same extent. They're going to have decreased mobility. And the majority of people are going to lie back in bed, and so you lose the positive effect that gravity actually has. Because when you are in labor, you need this baby pulled down, and gravity pulls down. So if you're in an upright position, walking around, sitting, moving position really nicely, okay, you are going to have that baby pulled down. If you're having an epidural, you lying in bed, you are losing that wonderful positive part of gravity pulling that baby down. And that is going to cause a longer labor. And because it's a longer labor, we're then going to need to have syntocinon added to it to actually get those contractions to try and become more effective. And then we're back here to all the problems that syntocinon can actually occur. Not only that, there's difficulty in pushing your baby out for some people if their epidural is really hyper effective at that particular moment when you are due to push. The other thing is that your epidural anesthetics often lead to weaker contractions, and so you're going to go back onto this path here, needing syntocinon to actually get them going to counteract that decreased contractions from the epidural. Because we are now at risk, at higher risk, things are no longer normal, you're going to be more likely for your baby to be continuously monitored. When you are in normal labor, you only need to be intermittently monitored for your baby's heart rate. So somebody listens to it, nice, regular, pounding heart rate, everything's great, and we don't go back there for another half an hour. Okay, and in that half an hour, you can be up, you can be active and mobile again. Whereas they actually tend to strap you down in the bed with this monitor, for want of a better description, this electronic fetal monitoring. So it monitors your baby very well and makes sure your baby is coping with the stresses around it. And so when you are continuously monitored, again, you can't walk around, you can't be mobile. It's a lot harder to keep changing positions because you affect the reading. And so with this less mobility, we again maybe have an increased risk of failure to progress. And so they are then going to need to do another intervention, and that being that they artificially rupture your membranes, brings that baby's head directly down into contact with that cervix. Okay, so that this baby's head stimulates the cervix to actually dilate. With this artificial rupture of membranes, they will probably then do internal fetal monitoring, where they put a little monitor thing just under the baby's skin on his scalp, and it monitors the baby's heart rate a lot more accurately than the external one. That can lead to an infection, and again, you might need antibiotics. And the problem with antibiotics and affecting mom and babies microbiome, their microorganisms, and the negativity there. Also, with all of these interventions and this internal fetal monitoring, you are more likely to need intervention because they are monitoring this baby's heart rate every second. And so any slight dip, they're going to say, oh, this baby's gone into fetal distress. And so they're then going to intervene quicker to actually try and counteract this baby's distress. Its heart rate might be slowing down. And so then you become more likely to have an assisted delivery, okay, to get this baby out quicker. We put forceps on or a vacuum, and we actually help pull this baby out, and this process is speeded up. Or if you aren't ready to push this baby out, because you can only use forceps when the cervix is totally out of the way, so that when you are now in the second stage of labor. But if the fetal distress occurs before then, you would need a Caesar. So you've gone through so much, and now you're needing a Caesar as well. Okay, let's check. Okay. All right. So, oh, and when there's fetal distress, you're more likely to need an episiotomy or a cut to actually enlarge that vaginal outlet, okay, to get this baby out quicker, or to actually make a bit more space so that you can get the forceps or the vacuum attached. And so, yes, an episiotomy becomes another one of the interventions that is actually needed. Okay, this is really not a great motivation for labor, okay, with interventions. It does sound very, very negative. The reality is all these things do have a chance and an increased risk of happening with every single intervention that is actually happening. So again, here, if we land up as a Caesar, whether we land up as a booked Caesar or a emergency Caesar, again, remember, with a Caesar, you need the antibiotics. It affects the mom's microbiome and the baby's microbiome. A Caesar doesn't give you the same wonderful opportunities generally, can interfere with skin to skin and give mom bonding problems, baby problems with stability, mom's feeling increasingly depressed and anxious, and breastfeeding problems, okay? Poor suck, poor latch, because the baby's not sucking nicely, okay, they become more jaundiced because the fluid actually isn't diluting the bilirubin that's in their body, and so it becomes more concentrated. This baby's bilirubin level increases drastically, and they need to go and have some phototherapy. Okay, go under the lights, and again, mom and baby are actually separated. A baby that's got a poor latch and a poor suck is more likely to become dehydrated because they're actually not getting the extraction of the milk properly. And a dehydrated baby would be more likely to land up in the NICU, and the problems with thrush, antifungals, and the change in the baby's microbiome. Also, if this baby has a poor suck and a poor latch, this baby is more likely to need formula feeding, okay? And once you introduce even one bottle of formula, that baby's chances increase drastically of getting allergies, okay? Because it changes that microbiome of the baby. And it really, even one mouthful of formula actually changes things drastically for your baby. So it really would be ideal if you could actually make sure that breastfeeding is what happens and that we don't actually need to have any supplementation of formula, that this baby actually sucks well off the breast and it's alert, goes through the 9 instinctive stages, latches nicely, and all of these complications actually decrease and fade, hopefully into non-existence. I hope that you've been able to follow this chart, follow what we're saying, understand the principle of what we're actually going through, that really what happens is that it is this cascade effect. You say yes to one thing, but yes, there might be another 10 steps down the line of problems that actually ensue. And this is not being unrealistic. This is not being melodramatic. This is being realistic of what you can expect and what you actually need to realize that you take on when you actually agree and need an intervention. Okay. Okay, then there's something particularly linked to inductions that we spoke about, this artificial way of starting labor. And this is very much, let's look at it, the date and the way of birth. What would your baby choose? Not what would you choose, not what is convenient for you, not because I want to be induced because I want my baby to be born on the same birthday as me, but what would your baby choose? And staying pregnant as long as possible, ideally 39 to 41 weeks, is the best way to give babies enough time in the uterus to grow and develop. So if we have a look at what is a preterm baby? Okay, a preterm baby is a baby that is born before 37 weeks. Now, under normal circumstances, pregnancy is classed as 40 weeks. Okay, so anything before 37 weeks is considered preterm. 37 to 38 weeks is early term. A full-term baby is classified as 39 to 40 weeks. Then you get your late term, those babies that just want to stay in that extra few days or extra week to 41 weeks. And then a post-term baby is anything from 42 weeks and beyond. Now, a baby born before 39 weeks is an early term baby. And each week of pregnancy matters, even those last few weeks. There's a huge amount of change that takes place in your baby as far as maturation actually goes in those last few weeks of pregnancy. And if we have a look at these schematics here of a baby's brain, particularly at 35 weeks, and the underdevelopment that is there, compared to the baby's brain that is really much more developed and matured, that is born at 39 to 40 weeks. A baby's brain at 35 weeks of pregnancy weighs only 2/3 of what it will weigh at 40 weeks. So can you see the enormous changes that are beneficial for this baby to stay in utero? Obviously, if things are normal and uncomplicated, that never underestimate how important it is for this baby to stay in for at least 39 weeks. So if we have a look at inductions, okay, natural labor, okay, versus an induced labor, okay. With the natural labor and you don't have any epidurals, okay, 5% will land up as Caesars. Natural labor, okay, which is 53% of people, the epidural rate is 61%, and the cesarean rate jumps up to 20%. If you have an induced labor and you don't have an epidural, your Caesar rate is 19%. But if you have an induction and an epidural, which is 78%, your Caesar rate chance jumps up enormously to 31%. Okay, so very, very important to try and cut down on those interventions, so it cuts down on the complications. Okay. And it's all about making informed decisions. Okay, so the myth is every type of birth is equal. The fact is the type of birth impacts you and your baby. The myth is you need an obstetrician gynae at every birth. The fact is only high-risk births need a gynae present at the birth. The myth is Caesar births are less painful than vaginal births. The fact, vaginal births experience pain during the labor. Cesarean births are painful after the labor, okay, because of its major abdominal surgery pain. Myth is if you're pregnant with twins, you have to have a Caesar. Okay, the fact is if the first twin is presenting head down in a good position, they can be born vaginally. Myth, my birth plan is the only way. The fact is the unexpected and unplanned can happen. Be prepared for both. Our ultimate goal is to have a healthy mom and a healthy baby. Myth, there is only one right way to birth. The fact is, it's okay to have expectations, but there is not a one-size-fits-all solution for giving birth. Your medical history and your body are unique, and your needs might dictate one birthing method over another. Myth is, if I have a Caesar, every birth thereafter will have to be a Caesar. The fact is, you can have a VBAC, a vaginal birth after cesarean, and that can be an option to investigate. Myth is, every intervention in birth is separate and isolated from another. The fact, which you should know by now, every intervention potentially leads to the next intervention. That's why it's called a cascade of interventions. So it's called use your brain, okay, a tool to navigate decision-making in labor. So if interventions are being suggested to you in labor by your gynae or your midwife, then here is a great tool for helping you and your partner decide if this is the right course of action for you. It will help you to ask the right questions about the intervention. And that's where brain comes in, okay? Part of it is, yes, use your brain, but actually, okay, it stands for other things as well. Because we've got to remember, birth is unique to every mom and baby. Issues can arise during labor, causing decision-making to become necessary. The intervention rate during labor is high, so use brain to help you navigate your way through labor to decide what interventions you are willing to have and when. So your B of brain is for benefits. So if somebody is saying, I think you need a Caesar, then you say, well, what are the benefits of doing a Caesar or taking this course of action? And your R is the risks. What are the risks of doing this procedure or taking this course of action? So in what we're talking about now is for a Caesar. What are the benefits? What are the risks? And your A is for alternatives. Are there any other alternatives to what I'm being offered? So if I really want a normal birth and I'm being offered a Caesar, is there perhaps an alternative? Your I is for implications and intuition. What is my gut telling me to do? Does this procedure make sense? What are the implications of following this course of action? And will it make further interventions more likely? And N is for nothing. What would happen if we did nothing right now? Perhaps waited for a while before doing anything. And once you've looked at the brain and used your brain, hopefully it will become obvious as to what we need to do. And as we said right at the beginning, there is time and place for every intervention, but you need to be making an informed decision. And this is what we're really striving to help you do tonight, is to know what you should be asking of who, when, and where, and how. Okay, so because Caesars are one of the interventions that actually happen, let's look at the ins and outs of Caesars. Okay, and this is when you've actually cut through the skin layer. You can see with a Caesar, you are actually in the middle, taking this baby's head up and out through the abdomen. Now, people often wonder when they've had a Caesar, why am I so sore? You know, isn't it just one small little incision and hey presto, this baby comes out? But actually it's not. There are layers to a Caesar. So here we can see this first layer that's depicted, and that's the skin. This is the belly button in the middle over there. Now, there are two options for Caesars. The most common is the bikini cut at your bikini line or your horizontal cut, okay? There is another option, a less nice option. It's not the one we would go for under normal circumstances, and that is your vertical cut. Okay, but sometimes, depending on how dire the emergency is to get this baby out, and perhaps the position and what the problem is, okay, an up and down cut is a lot quicker and exposes more to get this baby out quicker and see what is going on. So again, there is a difference. But basically, we are saying here, the first layer that you actually go through is the skin. Once we've passed through the skin, oh my goodness, we have a layer of fat. Some of us have a thin layer of fat, and oh my word, some of us have a big, thick, yellow layer of fat. But we go through the fat nonetheless. And after that, we go through another layer called fascia. And after that, we go through our muscles. Our abdominal muscles get cut. Once we go through the muscles, we get to the peritoneum, and we've got to go through that layer. And then we come to the uterus. We've got to mind that bladder out of the way, okay? Otherwise, we would go right through it. So we've got to move that bladder out of the way as we go through the uterus. And then we come to the membranes. Yes, we can see that baby, but there's still membranes to go through. And once we get there, we come to our baby. So you see, there's an enormous amount that is actually got to be cut and stretched and pulled to actually ensure that the different layers are actually cut really well and moved out of the way. There's a very cute little, it's called the Play-Doh cesarean, and the mum is a Ghani and her little one is helping her do a Play-Doh cesarean. But it just gives you a cute pictorial view of this cesarean. Nothing squeamish about it at all, so you can enjoy it. If I can just move this out of the way.
The anesthesia works, so you can go ahead and just pinch the tummy, see if the patient felt it. Does the patient feel it? Nope. Okay, we're good to go. And we're going to start by making a transverse incision on the lower part of the belly. What do you see? Good job. So we went through the skin and the fat, very good. This is the fibrous fascia. Now here's the rectus muscle. So we're just separating the muscle to the side. Okay, go ahead, separate to the side. So this is going to be our bladder blade. Keep it here to protect the bladder, which is under here. Here's the uterus. We're going to cut through the uterus. Yep. So that's the amniotic fluid, which is inside the amniotic sac. Do you see the baby? Do you think we can get him out?
I think it really deep.
Oh my goodness. It's coming out.
Oh, help.
Okay, we have a head. Okay, all right. So here's the baby. Congratulations. So we'll put baby's so cute. We have to deliver the placenta next. There we go. There's the placenta.
Hopefully you enjoyed that, and it's quite a nice visual thing that to actually see what is going on without it being all gory and bloody and all the rest of it. So hopefully you enjoyed that for a couple of minutes. So let's look at the evidence on inductions or cesareans for a big baby, because I'm sure that you have heard many people say, I'm being induced, I'm having a Caesar because I'm expecting a big baby. It's one of the most common reasons, common excuses that we actually hear. So let's look at what the evidence actually says. So what is a big baby? Okay, now the medical term for a big baby is macrosomia, and it literally means big body. And some researchers consider a baby to be big when it weighs 4 kilograms or more at birth. And others say a baby is big if it weighs 4.5 kilograms or more. Okay, and babies are called extremely large if they're born weighing more than 5 kilos. No, thank you. Okay, so let's have a look. This is the percentage of birthing people who have big babies in the US. Okay, it just gives us a, yes, I know it's not South Africa, but it does give us an indication of what goes on with big babies. All right, we're obviously looking in this second column, the non-diabetics, because people who are either gestational diabetics, so they become diabetic during their pregnancy, or they've got type 1 or type 2 diabetes, they are more likely, one of the complications is to have a big baby. And so we are excluding the diabetics from this discussion. Okay, we are looking just at normal non-diabetic average babies. And the actual weight at birth, 89.9% of babies are going to weigh less than 4 kilos. Okay, and we said the description for some that a big baby was above 4 kilos. Okay, so it's just over 10%, okay, that are actually going to weigh more than 4 kilos, okay, and really be a true big baby. 8.9% weigh between 4 and 4.4 kilos, and only 1.3% are actually over 4.4 kilos. Okay, so in some of the description, if we go back, is that some researchers consider a big baby to weigh over 4 kilos, and others say a big baby weighs over 4.5 kilos. Now, I'm sure if you count up how many people you know who had an induction or a Caesar for being a big baby, you can see that there are a lot that weren't actually true big babies that came out. Okay, so what factors are linked to having big babies? Okay, big babies run in families. This is a genetic phenomenon. Okay, and it's more common to have a big baby when the baby's sex is male. Now, people with diabetes before or during pregnancy have higher rates of big babies compared to people who are non-diabetic. Now, other factors that are linked to big babies include having a higher BMI, body mass index. So you are overweight or obese before pregnancy. You have a higher weight gain during pregnancy, an older age, post-term pregnancy, and a history of having a big baby. So what is routine care for suspected big babies? So although only 1 in 10 babies is born large, researchers found that 2 out of 3 families in the US had an ultrasound at the end of pregnancy to determine their baby size. And 1 out of 3 families in the study were told that their babies were too big. In the end, the average birth weight of their suspected big baby was only 3.5 kilos. So we can see that all these suspected big babies, actually, most of them turn out not to be big babies at all. Of the people who were told that their baby was getting big, 2 out of 3 said their care provider discussed inducing labor because of the suspected big baby. And 1 out of 3 said their care provider talked about planning a cesarean because of this big baby. So on ultrasound, you are having a big baby. So let's do an induction, or let's do a Caesar. So in summary, again, remember, we are not talking about diabetics. Okay, if a care provider predicts a big baby based on an ultrasound or physical exam, they will be right half the time and wrong half the time. Ultrasound weight results at the end of pregnancy can fall anywhere from 50% above or below the baby's actual weight. So we know at the end of pregnancy, the ultrasound is not an accurate way of determining what the baby's actual weight is. Okay, so don't be fooled. About 7 to 50% of big babies have difficulty with the birth of their shoulders, which is called shoulder dystocia. You can see in the picture over here, the shoulder gets caught under the symphysis pubis, under the pubic bone, and there can be a problem. Now, the chance of a permanent nerve injury due to shoulder dystocia happens in 1 out of every 555 babies who weigh between 4 and 4.5 kilos, and 1 out of every 175 babies who weigh 4.5 kilos or greater. And we saw what a small percentage of babies actually were anywhere near that 4 and 4.5 kilo weight. So if a care provider thinks that you are going to have a big baby, this thought is sometimes more harmful than the actual big baby itself. This is because the suspicion of a big baby leads many providers to manage labor in a way that increases the risk of cesarean and complications. Specifically, there's an increase in cesareans for labor being arrested or stalled labor when the care provider suspects a big baby. It's like, oh, I'm so worried about this big baby. And so you actually almost see things that aren't there, or aren't actually happening, even if the baby's actual weight is not big. So if a care provider thinks they're going to have a big baby, it is especially important that they follow the standard definitions of a slow labor. Okay, so although policy of very early induction, 37 to 38 weeks, can prevent some shoulder dystocia from occurring, researchers have not been able to show that induction decreases the risk of what is called a brachial plexus palsy, and very early induction may carry other risks to the birthing person or baby. And we can see basically in this picture, this baby's arm is affected from his shoulder down. It has affected the brachial plexus, which is the huge nerve supply under the arm. Now, policy of elective cesareans for big babies likely does more harm than good for most birthing people. It would take nearly 3,700 elective cesareans to prevent one permanent case of brachial plexus palsy in babies who are suspected of weighing more than 4.5 kilos. For pregnant people with diabetes or gestational diabetes, ultrasounds are slightly more accurate at predicting a big baby because people with diabetes are at higher risk of having a big baby to begin with. And just like for birthing people without diabetes, it is also very important for care providers to follow the standard definitions of slow labor. And elective cesareans may be more cost-effective in pregnant people who have type 1 or type 2 diabetes than they would be in those without diabetes. So based on expert opinion only, there may be some benefit to planned cesareans in diabetics with a suspected big baby estimated to weigh over 4.5 kilos. Management of gestational diabetes, so things like diet, exercise, medication, lowers the chance of having a big baby, and so shoulder dystocia brings it down to normal levels. So what is the Caesar, the C-section, the cesarean? Okay, and we said it is an artificial way of birthing this baby through an abdominal incision. but a cesarean should only be done for medical reasons, okay? There should be medical indication that says you should have a Caesar and a genuine medical reason. So you can have a C-section that is planned or booked, and this means that you and your healthcare provider decide when to schedule the Caesar based on your health condition, based on the condition of your baby, or a Caesar may be an emergency. And an emergency C-section has to be done immediately because either your health or your baby's health or both are actually potentially in danger. And if there are medical reasons to schedule your Caesar, talk to your provider about waiting ideally until at least those 39 weeks of pregnancy, because this gives your baby the time she needs to grow and develop before birth. And remember, it should be done for medical reasons only. So what are the reasons that are medical reasons for a Caesar? You may need a Caesar because of complications that make vaginal birth unsafe for you or your baby. And complications during pregnancy, you've had a Caesar in the past, or you've had other surgeries on your uterus, and the more Caesars you have, the greater your risk for pregnancy complications. And some women can safely have a VBAC after a Caesar. There are problems with the placenta, such as placenta previa, which can cause dangerous bleeding during vaginal birth. And what happens is that under normal circumstances, the placenta should be embedded at the top part, ideally, of the uterus. And a placenta previa means that actually it's over the lower part and probably encroaching over the cervix. So you can understand visually it as the cervix started opening, so you'd be bleeding because that is where the placenta is actually attached. So that one would definitely require a Caesar. If you have an infection like genital herpes or HIV, that can be passed on to your baby during vaginal birth, okay, a Caesar is often safer for the baby. If you have a medical condition that may make vaginal birth risky, things like diabetes, high blood pressure, preeclampsia, those sort of things are really important and good reasons for a Caesar. You're having multiples, okay, twins, triplets or more. We said if the first baby is head down, really nicely engaged, you can actually deliver vaginally. So that one is not 100% if you're having multiples that you need a Caesar, but it can be an indication. So complications that affect your baby and labor and birth. So if your labor doesn't progress, this means it's too slow or it stops. Perhaps your baby is genuinely too large. Your baby isn't in a head down position, that it's actually a breech where the bum or the feet come out first, or this baby's lying transverse right across. There's no way that this baby's going to fit. If the umbilical cord is compressed somewhere, or that cord has prolapsed and it's coming out in front of the baby's head, definitely a reason to actually do an emergency Caesar. If your baby is in distress, it means your baby isn't getting enough oxygen or his heart rate might not be regular, definitely an indication for a Caesar. If your baby has certain birth defects, okay, for example, like a hydrocephalus where there is too much fluid in and around the brain area, the head is too large to pass through vaginally, and one would actually need a Caesar. If your provider recommends scheduling a Caesar, ask these questions. Why do I need to have a Caesar? Is there a problem with my health or the health of my baby that makes it necessary to have my baby before 39 weeks? Can I wait to have my baby closer to 39 weeks? And what problems can a Caesar cause for me and my baby? What will my recovery be like? And can I have a vaginal birth in future pregnancies? Basically, we're going through the brain. Okay, so let's look a little bit at inductions. Okay, an induction is an artificial way of starting labor. Okay, your provider may recommend inducing labor if your health or your baby's health is at risk, or if you are 2 weeks or more past your due date. Okay, we don't let people go endlessly. Okay, there has to be a cutoff point for this baby to be born, and definitely not longer than 42 weeks. For some women, inducing labor is the best way to keep mom and baby healthy, and inducing labor should be, again, for medical reasons only. If there are medical reasons to induce your labor, talk to your provider about ideally wait until at least 39 weeks of pregnancy. Okay, gives that baby that time to grow and develop. And scheduling labor induction should again be for medical reasons only. You get a surgical induction, okay, where this amniotic fluid in front of the baby's head is actually ruptured. And the way they do that, they've got what is called an amnio hook, looks like a big crochet hook, and they just nick the membranes, which have got no nerve endings in it, so it's totally painless. They spread the membranes open, and this water in front of the baby's head gushes out. A medical induction, we've spoken about earlier, where you have a drip up with syntocinon in to actually cause those artificial contractions in your uterus. So what are the medical reasons for you inducing labor? If your pregnancy lasts longer than 41 to 42 weeks, absolutely. Because what happens is that the placenta might start to not to function as well as it has been. And so it becomes safer for your baby to be out than in, so that it gets enough food and oxygen, etc. Your placenta is separating from your uterus, or you have an infection in your uterus. Your water breaks before labor begins, that premature rupture of membranes. Okay, we need to then get that baby out, because all the lines to protect against an infection going to your uterus and to your baby have now been worked through, and so we need this baby out for it to stay healthy. If you have health problems like diabetes, high blood pressure, preeclampsia, problems with the heart, lungs, kidneys, okay, that is definitely a reason for an induction. If your baby has stopped growing, or your baby has oligohydramnios, that means that it doesn't have enough amniotic fluid around it, becomes dangerous for your baby. Again, we need to get this baby out. And if you have RH incompatibility, and it causes problems with your baby's blood. So what are the risks of scheduling labor induction for non-medical reasons? Induction may cause problems with you and your baby because your due date might not be exactly right. Sometimes it's hard to know exactly when you got pregnant. If you schedule labor induction and your due date is off by a week or two, your baby may be born too early. And prem babies have many more health problems at birth and later in life. And so out of choice, we definitely don't want to have a prem baby. And this is why it's important to wait till at least 39 weeks to induce. If your pregnancy is healthy, it's best to let labor begin on its own. If your provider talks to you about inducing, ask if you can wait until 39 weeks, because it gives your baby's lungs and brain all the time they need to fully grow and develop and mature. Okay, so what are those questions we should be asking? Why do we need to induce my labor? Is there a problem with my health or my baby that they want to induce me? Can I wait to have my baby close to 39 weeks? How will you induce my labor? What can I expect when you induce labor? And will inducing labor increase the chance that I'll need to have a Caesar? And what are my options for pain medication? Now I'd like to introduce to you something that is called gentle cesareans. And some of you may have heard about it and some may not. And it is really a stunning alternative if you've got to have a Caesar, is to actually have a gentle Caesar. Not everybody offers it, but it is actually quite interesting. And it is a nice option if they do offer it. So one's got to remember a cesarean is more than just surgery. It's actually the birth of your baby. And a cesarean can be more than surgery. So gentle Caesars facilitate the mother's participation in that first moment of a baby's life. She's able to see her baby as it is born. If we go back, look at that, as that baby is coming out. So instead of those material drapes, there's a see-through drape, and that mom can actually watch her baby being born, which is amazing. Environmental accommodations for a more tranquil experience. Receiving the baby immediately after birth. Facilitating development of the microbiome and baby's immunity through immediate skin-to-skin contact and vaginal seeding. Facilitating the physiological synergy between mom and baby after birth. An experience, mom or dad can actually even cut the umbilical cord of the baby. So Nobel in his research in 2007 says traditional cesareans can prevent mothers from connecting with the important physical and emotional aspects of birthing. Their higher negative perceptions about their birth, themselves, and their babies. And the research shows poor maternal-child interactions. There's this distance between mom and baby that can be very pronounced. And there's also a higher risk of postpartum mood disorder for the mom, because she's missing out on seeing that birth of that baby and participating in this birth. So all the clinical, safe and sterile procedure in the operating theatre remains exactly the same, but there's a process change. So you can actually watch the birth of your own baby from where the head is lifted out of the incision and the drapes surrounding the Caesar being down or lowered or see-through. And the doctor can conduct a slow delivery, walking the baby out with the intent to imitate the vaginal squeeze to shift the fluid from the baby's lungs. So basically, when a baby is born vaginally, it can be a slowish process. So this baby comes out and it needs to rotate, and then the head rotates, and then the shoulders rotate, and then the body rotates. And so this baby undergoes this whole movement of rotation. And that is very, very vital in actually getting good development later in the baby as far as senses go and development goes, because this is the normal process. And by walking the baby out, okay, after the Caesar, it's mimicking this baby actually coming out in that way. So all the benefits to both mom and baby of skin to skin immediately at the birth apply to cesarean births too then with these gentle Caesars. So the mom's dominant arm must be free to hold her baby. Okay, the blood pressure cuff is covered, the ECG dots are away from mom's chest, they're on her back or right at the top. And once the umbilical cord is cut and any stimulation required initiated, a surgically sterile staff member receives and places the baby on the mother's chest. She dries the baby, puts a beanie on the baby's head, and all these procedures are done while the baby's on the mother's chest. Isn't it a fantastic option? And this naked baby is then placed prone on the mother's chest. The head and back are draped with a warm towel covered by a sheet of bubble plastic, and through thermal synchrony, the skin-to-skin contact allows the mother's chest to warm the baby's body. And the newborn care tasks can be done while the baby's on the mother's chest, so that there's no separation of mother and birth, which routinely happens with Caesars, and hence less colonization of hospital microorganisms for the baby, and rather that it gets its mothers and a much healthier microbiome formation. Dad can do skin to skin with his baby under his hospital theatre scrubs when mom is being transferred onto the trolley, and baby's put back skin to skin with mom once the transfer to recovery has occurred, and she's then assisted in initiating breastfeeding in response to baby's cues. So this also actually minimizes extra noise for everybody. It minimizes the non-birth related conversations between members of the clinical team. The evidence proposes that selected audio-visual media used during surgery can produce an anxiolytic. It takes away the anxiety effect, okay, in the patient by decreasing activity in the nervous system and decreased neuromuscular arousal. It's a mind shift, okay, for everybody when one thinks about gentle Caesars. And the perioperative team utilizes an evidence-based approach that facilitates physiological and psychological benefits for both mom and baby. And the biggest barrier is people's power and reluctance to change, particularly within the professional team during the Caesar. Oh, but Caesars have always been done this way, and this is a whole mind shift for them. All elements of gentle cesareans are refinements of standard practice that will positively impact on mothers, fathers, and babies for the rest of their lifetimes. So mothers dream about the moment of birth and holding their baby and soothing their baby's cries. And the surgical nature of a cesarean detracts from valuable elements of birth. Minor changes allow the mom and dad to witness the birth, experience skin to skin and bonding with their baby, improve the baby's temperature, breathing and blood sugar regulation, and reduce stress for the mother and the baby. One is definitely got to realize, though, that advocating for a gentle cesarean must not be confused with promoting elective cesareans. A gentle cesarean is only there if somebody is medically needing a cesarean. We're not saying, oh yes, we'll have a Caesar if you want it, and just ask for a gentle one, and it's going to help counteract some of the negative problems that occur with Caesars, particularly with the baby. No, the prospect of more patient-centered, kind and gentle cesarean care for mothers and their babies is definitely exciting. And the natural cesarean, a woman-centered technique. Now, I managed to find a little video clip of a natural cesarean or a gentle cesarean. So let's have a look.
Oh, chocolate shake. She's crying. She's crying. Thanks, sir.
Okay, hopefully that you enjoyed it. It's a very slow process, whereas when under normal circumstances, this baby comes out very quickly, kind of all together. Yeah, what can I say? Good, let me just see. Please, if you've got any questions, put them in the chat box, because looking at the water births is just a little bit of an extra. So type in all the questions that you have about Caesars, inductions, cascade of interventions, anything that we've talked about tonight that you want clarified or hasn't been talked about. And while you do that, I will go through a few minutes of water births. Now, research has verified many aspects of water labor and water birth. Okay, so we can use water to labor in, but we can also use water to actually birth in. So water facilitates mobility and enables the mother to assume any position that is comfortable for labor and birth. I'm sure all of you, when you have had some form of pain before, you've just gone and climbed into a nice, deep, warm to hot bath. And it's amazing what that pain actually, how it is reduced, how really nice it is, what different positions you can actually get into. That warmth speeds up labor. It lowers the mom's blood pressure. It gives moms a feeling of control, okay? And it provides significant pain relief. Water is actually the most important natural pain relieving technique you can use when you are in labor. It promotes relaxation. It conserves the mom's energy. It reduces the need for drugs and interventions. It gives moms private protected space. It reduces perineal trauma and to a large extent eliminates episiotomies being cut. It reduces cesarean section rates, and it's highly rated by mothers, typically stating they would consider giving birth in water again, some even stating they would never give birth any other way but in water. It's highly rated by experienced providers and encourages an easier birth for mom and a gentler, slower transition. And for this baby is in water for 9 months, and it comes out slowly, transitions through water again, and then is born out of the water. Now, Barbara Harper from the US, who specializes in the research of water births, talks about how having a pool of water in a labor room actually changes the atmosphere of the entire birthing environment. She commented on how the voices get softer. Everyone feels less stressed. the mother actually stays calmer. She goes on to describe how the buoyancy of that water when the mother is immersed in deep water allows the mother to be able to move spontaneously and more easily into a new position. She can move as her body tells her to assume a different position in the water. Movement of the mother into different positions helps to open the pelvis and allows the baby to descend deep through the pelvis. Gravity doesn't interfere with this mother's movements because of the water, and so too she's able to relax better and give her body the likelihood of producing less stress-related hormones, so her labor can progress quietly and stress-free and optimize her labor. This also allows her body to produce more endorphins, so her body can naturally cope with the pain of labor. A laboring woman who is able to relax physically will be more able to relax mentally as well. Factors that prevent the newborn from inhaling water at birth in a water birth, because everybody says, oh, won't this baby drown? There are skin receptors on the face, and as they go into the water, they actually have not come into contact with the air, and so this baby doesn't take its breath. Endorphins are released by the brain, and hormones, including prostaglandins, progesterone, estrogen, and adenosine, are released by the placenta. A warm temperature of about 37 degrees. Okay, so this baby's coming out into body temperature water. There is no trigger for this baby to breathe. Okay, if it came out into really ice cold water, there would be more of a trigger for it to breathe. They're mildly low oxygen levels, and the chemical receptors detect water and close the airway in the so-called dive reflex. So, fact or fiction? Is water birth less painful? The truth, according to multiple studies, people who labor and give birth submerged in water report lower levels of pain than people who do not give birth in the water. And studies also report decreased anxiety, and multiple research teams found a significantly reduced need for pain relief, including epidural. The reality, while the majority of people report reduced pain and increased satisfaction with a water birth, it's important to remember that pain is subjective. It's unique to each individual. And so what works for one person may not necessarily work for another. So ideally, in your chosen place of birth, submerging in water is one of the many options available to you as you labor and as you birth. Some hospitals allow you to labor in water, but request that you get out of the water to give birth. Water birth bath rentals are available for use at home births. And if you want to read any more on water births, a great place to go and read is waterbirth.org, as well as evidencebasebirth.com/waterbirth. And those will give you both research information on water births. So hopefully you have found that interesting, enlightening, and hopefully you will go on to actually read more, use your brain more, and go on to have the most amazing birthing experience.